Welcome to Oncology Today, key presentations in AML and MDS from the 2022 ASH meeting. This is medical oncologist Dr. Neil Love. For this program, I met with Dr. Richard Stone from the Dana-Farber Cancer Institute, and to begin, before we review the ASH papers, I asked Dr. Stone to comment on the recent evolution of AML management over the past few years and where he thinks things are heading in years to come.
I would say, like in The Graduate, when Paul Newman was told about plastics as the future, it's all about molecular and targeted therapy. I'll add that in. That's where the field is going, and I'll give you some obvious examples from this year's ASH about that. This is certainly true in AML and not so much in MDS, but that may be coming. So from the standpoint of AML, not only is molecular knowledge of the patient's leukemia critical, but this is now entered major league into the realm of therapy for AML. And AML has been known for a number of years that it's a heterogeneous disease, but now we're leveraging that heterogeneity by having different targeted therapy, either alone or with chemotherapy, in a host of subsets in younger adults with AML. And actually in older adults with AML, the therapeutic landscape is smoothened to a certain degree because of the advent of the azacitidine venetoclax doublet. But that will be changing to include triplets for patients with targeted therapy, as we'll see some examples of in this year's ASH. In MDS, right now, the big change is the impact of molecular on prognosis based on the release of the IPSS-M, which is finally brings in the molecular landscape of a given patient's AML into the prognostic scoring system. This hasn't yet reached the realm of predictive value. In other words, we haven't quite shown that patients in certain risk groups defined by the IPSS-M should have certain therapies, but it's a start. So I think that's going to be the big thing. More targeted therapy in AML, younger adults, possibly more targeted therapy in the form of triplets for AML and older adults. And in MDS, we have possibly newer therapies coming down the pike, but that's less certain.
What about the actual diagnosis of AML versus MDS? I'm kind of starting to get the feeling that to some extent it's a continuum. What's your vision in terms of how that's going to proceed over the next few years?
Well, that, as usual, Neil, is a great question because just this past year, there seem to be dueling classification systems. There's the WHO, which updated its definitions of myeloid malignancies, and the ICC, or International Consensus Consortium, which I was a part of, came out with a paper in Blood detailing their view. I think the major issue is the blast count. It turns out that patients with above 10% blasts pretty much all behave like AML. So the 10 to 90% blasts that is still considered MDS by the WHO and was considered MDS generally is now falling into an overlap syndrome called AML/MDS, which seems maybe stupid, but the idea really is to allow such patients to be eligible to be treated or put on clinical trials for AML or MDS, depending on what seems best for that patient. We all have been, those of us who do clinical research in these fields have always been perplexed by the seemingly arbitrary situation where a person with 19% blast can only go on MDS trials, where a person with 20% blast can only go on AML trials, when the molecular features of the disease really are more important than the blast count.
The one final thing I wanted to ask before we get started, though, particularly for people who are new to oncology, and of course you have a big fellowship program, Dana-Farber, et cetera, can you kind of put in perspective the face of AML in older patients over the past 3 to 5 years, really since the approval of venetoclax HMA? I guess my perception was before that time, supposedly there were people actually not even getting treated. And I'm curious what you're seeing now as you see HMA venetoclax infiltrate into the community setting in terms of the face of what's going on right now in these older patients.
Well, I'll get into that in a second within the talk, but just generally speaking, it has changed the face of older adults with AML from a fairly hopeless disease to one with at least almost 2 years of median survival in some cases, depending on the molecular subtype. So, aza-ven is a little bit more toxic than azacitidine alone, but it's so much more effective, as you'll see momentarily based on the update of the VIALE-A trial, that I think there's a greater willingness to treat an AML patient. Now, I can't tell you whether more older adults with AML are being treated now thanks to aza-ven than was true when we only had AZA. I think it's certainly true that when we only had AZA, there were more older adults being treated than we had when we had low-dose cytarabine. But it still takes some resources to treat an older adult with AML with aza-ven because it is myelosuppressive, and you have to know what the drug-drug interactions are. You have to know when to hold and when to fold. And so it does take some expertise, but I think it easily can be done in the community with the proper amount of experience and training.
All right, well, let's go ahead and have you go through your talk.
Thank you, Neil. Well, my name is Richard Stone, and I'm the Chief of Staff at Dana-Farber Cancer Institute and the Director of Translational Research within the Leukemia Division, which is in the Department of Medical Oncology here at Dana-Farber. And I'm a professor of medicine at Harvard Medical School, the Lunder Family Chair in Leukemia. So it's a great pleasure to review some of the findings and abstracts that were presented in the field of AML and MDS at the American Society of Hematology meeting in 2022. It was held in December. So I'm going to begin by talking about an update of perhaps the most important trial done for older adults with AML in the past few years. The original results of this trial were published by Courtney DiNardo with the New England Journal of Medicine 2 years ago, and this is the VIALE-A trial, which is a phase 3 clinical trial comparing the then standard of care for older adults with AML, azacitidine, to what turned out to be the new standard of care for older adults with AML, namely azacitidine plus the BCL2 inhibitor venetoclax. The original result showed an improvement in the overall survival of all patients who were over age 75, and the trial also included patients who were under age 75 with significant comorbidities. And I would say since then, for the average patient with AML greater than age 75, as I mentioned, this has become the standard of care. Dr. Keith Pratt from the University of Pennsylvania presented an updated picture of the VIALE-A trial with 100% of overall survival analysis. And fortunately, the results that were published in the New England Journal of Medicine by DiNardo were confirmed. You can see now the median follow-up time is about 3.5 years. And the results of superiority for survival of patients randomized to venetoclax plus azacitidine was maintained compared to survival of patients randomized to placebo plus azacitidine. You can see that the long-term survival still is not anywhere near what we'd like to see, with 20% roughly long-term survival, but the median survival was 15 months in Ven-Aza and 10 months in placebo-Aza, with a very significant hazard ratio, indicating a 42% reduction in mortality for those who are randomized to aza-ven. So the question comes, what can we do to improve upon this, and which patients benefit the most? Well, Dr. Pratt also presented data showing, if you look at the bottom first, that those who achieved MRD negativity with Ven-Aza, which is the top orange curve, I think it is, did pretty well, with a median survival approaching 34 months. So which this says, of course, is that if you respond, you do well. This is nothing new, but it does show that MRD can be a surrogate for long-term good outcome. And those on the top who have IDH1 or IDH2 mutations do particularly well with aza-ven, and they benefit quite a bit more than they would if they had been randomized to placebo. So the question is going to come up, which I'll note briefly in a few minutes, is that there is a new regimen for IDH1 mutation older adults, namely that of the experimental arm in the Agile trial, which compared azacitidine to azacitidine plus ivosidenib, which is an IDH1 inhibitor, which showed a big improvement in overall survival. So we don't know yet how to treat the average IDH1 mutant older adult who could get either aza-ven results pretty good, as you can see here, or could get ivo-aza results very good, as were in the Agile trial published by Montesinos in Blood. Dr. Donor from Ulm, Germany, analyzed the VIALE-A trial plus a more preliminary trial in which ven-aza was given without a control group to a bunch of older adults with AML and tried to understand who benefited the most from aza-ven using molecular studies. And he looked at a lot of different mutations and found that those who had TP53 mutations didn't do all that well. No surprise, that's a recurrent theme. That's an unmet need in AML, TP53 mutations. But if you were TP53 wild type, did not have a FLT3 ITD mutation, did not have a KRAS mutation, you did pretty well, and there was an intermediate group here too. So this brings up the question of whether we should be using a FLT3 inhibitor to try to bring this middle group up to the top group if it really works. And we'll see some data about that in a few minutes. Now, a lot of people think that the venetoclax dosing that was in the VIALE-A trial is too aggressive. It's given continuously. And this group from France, led by Chris Willikins, looked at 7 days of venetoclax dosing, only giving during the days that the patients got the venetoclax. And although this was not a randomized trial, the median overall survival was similar, but not quite as good as we saw in the VIALE-A trial, in which the venetoclax was used continuously. This is 7-day venetoclax, high complete remission rate. So I think this is intriguing, and whether somebody will do aza-ven 28 versus aza-ven 7 or ven 14 remains to be seen. But most investigators don't end up using the full 28 days of venetoclax. We think it's too much. Now, going back to that Agile study I mentioned before that was published by Montesinos in NEJM last year, showing that ivo-aza was better than aza, Dr. Donor looked again using molecular studies to see if he could determine what the cause of resistance was in those who relapsed on ivo-aza and how deep the remissions were. Well, he found that ivo-aza frequently clears the mutation, so it was a very deep response. Resistance in non-IDH dependent fashion is more common, but triplets are being developed where ivosidenib is combined with aza-ven that might be the future, as I mentioned a few minutes ago.
Just a couple of follow-up questions. Could you just talk briefly about kind of what you recommend or how you approach the issue of, using aza-ven in terms of cytopenias when you do your first bone marrow and how you adjust dosing?
Good. So that's a great question. Well, I think during the first cycle, if the patient's counts are low, which almost they always are, between day 21 and day 28, I do a bone marrow. Just like I would do a day 14 bone marrow after 3 and 7, I do a bone marrow between day 21 and day 28. And the reason I do that is because if the marrow is empty of blasts, then I will wait until there's some count recovery to give the next cycle. And I'll also stop the venetoclax at that point. Whereas if the bone marrow still has blasts in it, then I proceed ahead on schedule and accept the cytopenias, which in this case, by definition, would in part be due to the leukemia cells. So that's what we do. And down the road, if a patient's in remission, we'll have a very low threshold to decrease the venetoclax dosing to 21 days or even to 14 days. Secondarily, we'll decrease the duration of azacitidine from 7 to 5 days, or sometimes thirdly, we'll decrease the dose of azacitidine from 75 milligrams per meter squared to 37.5, et cetera. So there are a lot of dose reductions, but they're only appropriate if the patient's in remission.
One other thing I was going to ask about is the issue of adverse risk factors and aza-ven, because I kind of had the thought, from an outside perspective that HMA venetoclax was effective regardless of, for example, P53 status, et cetera. And then it seemed like people started to change the way they view things when they saw the survival data. Can you kind of explain that a little bit? Because it still seems like you have higher response rates in these patients. I'm not sure how useful that is unless they're going to go to transplant, but maybe they can. So can you kind of educate me a little bit more about the impact of aza-ven based on risk status?
Yes, very important question. So all subgroups in the original trial and in a couple of papers published afterwards suggested all subgroups benefit from aza-ven compared to aza. However, the magnitude of the benefit is markedly different depending on the molecular subtype. Let's talk about P53. In P53 mutant patients, particularly if the variant allele frequency is above 10%, and particularly if they have adverse chromosomes, the benefit of aza-ven compared to aza is very minimal. Unfortunately, I don't really think that aza-ven adds much to aza alone in P53 mutant patients. And so many people take the attitude, yes, the response rate's a bit higher with aza-ven compared to aza, but the survivals minimally are not affected. And I don't think aza-ven, it really deals with the P53 mutant clone at all. It just enhances chemotherapy and chemotherapy responsive subtypes. So many doctors have taken to just giving aza or doing nothing, actually, for people with P53 mutations, particularly if they're high VAF or associated with adverse chromosomes like monosomal karyotype. You're just hurting the patient. And so it's almost therapeutic nihilism for these patients because it just makes them sick. Now, you talked about the response rate being a bit higher. They're probably mainly cosmetic responses because if you look hard enough, you're going to find that P53 mutation before the transplant. Yeah, depending on the age of the patient, we'll try to move them to a transplant in most cases. But we know that if they go into the transplant with P53 mutations that are detectable, they're going to relapse by and large. There's a few patients who won't, but it's rare. So it's a question of utilization of resources. So I think in every case except for P53 mutations, there's no hesitation to use aza-ven. But for P53 mutations, it's still pretty unclear. It's not wrong to use aza-ven, but it's not wrong to use aza either.
So another question is, I kind of initially, when I first started to hear about IDH, I was kind of had the take that it's very similar between IDH1 and 2. And more recently, I'm starting to hear people differentiate IDH1 and 2 disease response to therapy. Again, what's your take on that?
My take is that IDH2 disease is a little bit more resistant than IDH1 disease. It may be a difference without a distinction. I mean, the key distinction right now is that there's two different drugs for each of the subtypes. So that means the developmental pathways have been different. The approvals are different. The trials are different. For example, there's been no huge trial of ENA, which is the IDH2 inhibitor, aza, versus aza, analogous to the AGILE trial, which is ivo-aza versus aza. We can only speculate on the outcome. There was a phase 2 trial done by DiNardo of ENA-aza versus aza, and there was no survival difference, but it was a small trial. And a lot of the people who got aza eventually got enasidenib, whereas in the European trial, the AGILE trial, you couldn't just, because you were in Europe, you couldn't just get ivosidenib if you failed aza alone because of the different regulations there. So they're different. The IDH enzymes in a different part of the cell. There are subtle differences, but I think they're more similar than different, to be honest with you.
And did I see that there's a new IDH inhibitor that was approved?
Yes, olutasidenib, or if I said that right, it's from, I don't know if you want to say the name of the pharmaceutical company that makes it, but it's from another pharmaceutical company that most people haven't heard of unless they do rheumatology. And the results seem to be at least as good as with ivosidenib. So now for this rare subtype of AML, it accounts for 9% of all AML patients. We have two drugs, olutasidenib or ivosidenib, which just makes pronunciation difficult. The results, if you look them, of course, there was no head-to-head comparison, but the results in terms of duration of response and response rate seemed to be equivalent or maybe a little bit better for the new drug. But of course, that was based on a phase 1 trial and a phase 2 trial. So no phase 3 trials yet.
All right, please continue.
So speaking of IDH mutations, my friend Dr. Aiton Stein from Memorial Sloan Kettering published this BEAT AML subtrial in which he tried to figure out whether a person with IDH2 mutant AML could receive enasidenib as a single agent and then get azacitidine added to the enasidenib if they didn't respond. So the trial was that if everybody got enasidenib for their IDH2 mutant AML as a single agent up front, and then in the patients who failed, there were 17 of them, then they got azacitidine added. What this showed is that you can still achieve remission if you didn't respond to the single agent enasidenib by adding azacitidine. So again, this suggests that maybe in this particular subset of IDH mutations, IDH2, you can get away with single agent enasidenib and save the azacitidine and its toxicity for when they fail, although there's no randomization, so I don't really know. Most of the patients got enasidenib as a single agent. The response rate was equivalent to what was seen in the trial that he originally published in Blood, which led to the approval of the agent, at least in relapse refractory AML. This is an upfront AML. And there was still a 24% CR rate if azacitidine was added after failure of ENA alone. So we still don't know how these patients would have done if they were originally treated with aza-ven, which is, again, the standard of care in many places, because the one advantage, which I did mention before, is that you don't have to know the molecular subtype. If you're 75 years or greater, you can just throw them on aza-ven because that applies to everybody with the possible exception of P53 mutation. So let's talk about maybe the next generation in clinical trials. We're not going to talk about the aza-ven IDH1 triplets, although they're very promising, but we will mention the aza-ven gilteritinib triplet that has been studied at MD Anderson, and this was presented by Nick Short from that institution. And the problem with these triplets is that they're not for the faint of heart. Gilteritinib is a KIT inhibitor and is myelosuppressive in its own right. You're adding it to 2 other myelosuppressive drugs. So they give it the aza-ven as standard dosing. They do a bone marrow mid-cycle. They use a little bit lower dose of gilteritinib, which then is approved as a single agent for relapse refractory disease, namely 80 milligrams. And they give a little bit lower doses of the gilteritinib in consolidation if the patient achieves remission. And there's a bit of legerdemain about when you hold the drug, but the response rate in the MD Anderson hands in newly diagnosed FLT3 mutant patients, I'd say it's pretty good, 100% composite response, but most of the responses are actually CRs where the count recovery is seen. So this isn't, it isn't as good in terms of count recovery in the relapse refractory setting, but in the frontline setting, it's quite good with short follow-up, very good median survival. So we'll need to get more practice, if you will, with this triplet, but I see the future as possibly being triplet and maybe then gilteritinib, as was published by Dover and Pearl, as the way to treat refractory patients. But once everybody gets aza-ven gilteritinib up front, if they ever do, then the refractory patients will be treated differently.
Is there a phase 3 trial looking at that triplet?
Not yet. The U.S. cooperative groups are banding together to do what's called the MyeloMatch trial, which is going to investigate triplet in both younger adults versus aza-ven, versus 3 and 7 midostaurin or quizartinib versus a triplet and of aza-ven plus a FLT3 inhibitor that could actually result in the discarding of 3 and 7 in younger adults with mutant FLT3 AML if it's a positive trial. And then there'll be an older adult trial of the doublet versus the triplet. So yes, there will be randomized trials done by the U.S. cooperative groups. There'll probably be other ones done by companies or by Europeans.
Do you think it would take phase 3 to get it into practice, or do you think people might do it just based on the single arm?
I'm sure people are doing it now. I wouldn't recommend doing it outside the context of a clinical trial, but that's easy for me to say. Once Dr. Short's paper gets published and there's a more broad, at least literature experience with it, I think people may use it for their patients as upfront. Certainly as a relapse strategy, for the moment, it may be as good as anything else, but we don't know that either.
Are you yourself doing it outside
No.
of trial?
No. We have a clinical trial for patients who have younger adults with AML with the FLT3 that compares 3 and 7 mito to 3 and 7 crenolinib. And for older adults, we tend to use azacitidine, although we're considering joining a drug company trial with the triplet.
All right, please continue.
So speaking of FLT3 inhibitors, as most people know, the standard care for chemo-fit, mostly younger but not all adults with FLT3 mutant AML is 3 plus 7 plus midostaurin based on the ratified trial, but there are certainly more potent and less toxic FLT3 inhibitors out there, one of which is quizartinib, which is a type 2 inhibitor, so it doesn't hit the FLT3 TKD, but it is very potent against the FLT3 ITD mutation, which is more common compared to the two mutations. And this Quantum First trial was presented by Dr. Erba at the EHA meeting in June of 2022. The design was pretty straightforward. The standard arm was 3 plus 7 plus placebo. And the experimental arm was 3 plus 7 plus quizartinib. So this was very analogous to the ratified trial, not to a comparison of this FLT3 inhibitor against midostaurin. So the results were roughly similar to that seen in the ratified trial, although the patients were older in this trial, and there was a survival advantage for patients randomized to chemo quiz compared to chemo placebo. So at this ASH, Dr. Levis looked at some interesting molecular data. He has developed a MRD assay where he measures the FLT3 burden, mutational burden in patients after therapy. And not surprisingly, on the right here, he showed that the patients who were randomized to quizartinib had a lower level of disease measured by this FLT3 assay compared to patients randomized to placebo. And also, not surprisingly, which is definitely a recurrent theme, which is definitely going to be something more important in the future, he showed that MRD negative patients, however they got there, did better than patients who were MRD positive. So it's always better to be young and thin than old and fat, and it's always better to be MRD negative when you have AML.
What's your practical take on quantum? I guess it started before, I guess Ratify wasn't, the data weren't available. It would have been nice if they compared it to midostaurin. I'm guessing there's not going to be a phase 3 trial comparing it to midostaurin. Maybe I'm wrong about that. But right now, looking at the data, would you like to use quizartinib? And if so, why?
I think it's fine. I don't think it may be a little bit better tolerated than midostaurin. Just have maybe more QT problems, maybe more count recovery problems, and there's a lot of relapses with the TKD mutation. So I don't feel the need to change. I don't have any problem with using it. It's not approved yet for upfront use. It probably will be. I'll be waiting for the results of the comparative trials of 3 and 7 mito versus 3 and 7 gilteritinib, because gilteritinib will probably be the drug of the future in this setting. That's what I think anyway.
Do you think that gilteritinib is more effective in ITD than quizartinib?
Probably as effective. I mean, quizartinib is a little bit more specific, but I don't think it'll be possible to discern a difference unless you do a gazillion patient trial, because the results will be so good with either.
And when is that gilteritinib trial likely to report?
I think probably by 2024, because there's 2 gilteritinib versus mito trials. One is the PRECOG trial led by Dr. Luger of Penn. The other one is a Hovon-Sack multi-world trial that's a larger trial, but I think you'll hear about both maybe late this year or early next year. Just a guess, though.
All right, please continue.
All right, so there was many trials and many presentations from the MRC, from our colleagues over in the United Kingdom, about some of the key trials that they've done. And their trials tend to be a bit complex, but I'll narrow this one down to the AML 19 trial dealing with fit younger patients with high-risk AML or MDS. So these are patients who have bad prognoses based on chromosomes and or molecular studies. So let's keep that in mind. A lot of them have what we would consider secondary AML based on chromosomes or molecular findings. So they compared what they consider their standard induction regimen, which is FLAG-IDA, to liposomal encapsulated daunorubicin cytarabine, which is developmentally called CPX-351. And the overall results of the trial, which they presented last year, did not show a benefit for either of these agents over the other. So CPX-351 and FLAG-IDA were the same. But as always, and you can see the survivals weren't too encouraging in this bad group of patients because many of them have had p53 mutations, and as previously mentioned, this is a chemotherapy-resistant subtype. But what this paper by Dr. Othman dealt with was whether there was a molecular signature or subtype that might benefit from one therapy or another. And I think this is a very important way to glean more information from a trial, especially one that's seemingly negative, didn't meet its primary endpoint. So they looked at various subgroups and didn't find any difference between CPX and FLAG-IDA except for this one. And this is close to my heart because Dr. Lindsley, who works with me and is a brilliant junior colleague of mine, and I, along with Ben Ebert and Donna Newberg, published a paper in 2015 in which he showed that there were mutations that, whether or not we thought the patient had prior MDS, were highly associated with MDS. And they listed here ACXL1, RUNX1, EZH2, BCOR, SRSF2, STAG2, SF3B1, U2AF1, and ZRSR2. These are called myelodysplasia-related gene mutations. And amazingly, for reasons that aren't entirely clear to me, but it's true that if you had one of these mutations or more, you did better with CPX-351, as shown on the right, than with FLAG-IDA. And whether this is because CPX-351 gets into the marrow for a longer period of time, should we begin to choose CPX-351 rather than a more intensive induction therapy like FLAG-IDA in this subgroup of patients? That will still have to be confirmed, but I think it's a very intriguing paper.
Just to pick back up on CPX, in what situations are you thinking about CPX right now? To me, these patients would have been thought about it before. It's great to see the data on the specific, mutations and all, but does it really change clinically when or you use CPX?
Right. So it might. I don't think this paper alone will, but it'll make me think. Right now, the major confusion or clinical dilemma is whether to use aza-ven or CPX-351 in patients with bad prognoses, because we know that chemotherapy doesn't work and CPX-351 is really chemotherapy. And Lindsley did a post hoc analysis of the CPX versus 3 and 7 paper and showed that people with p53 didn't benefit from CPX compared to 3 and 7, and 3 and 7 doesn't work very well, so you might as well use venetoclax-aza. And we talked earlier that venetoclax-aza doesn't work very well, so you might as well use azacitidine alone in those patients. So for p53 is still a bugaboo. But in this particular subset of secondary ML, that is with these particular MDS type mutations, we don't know any data about venetoclax-aza yet, really, versus CPX-351. But it's intriguing to think that that might be the sweet spot where chemotherapy might actually work somewhat. And if you have this special agent, maybe that's the reason that they should be on. Remember, a lot of these patients have these mutations but don't have a history of MDS or treatment-related leukemia or MDS-related chromosomal abnormalities or even MDS-related morphology in their bone marrow, which would make them eligible for CPX-351. So what I'm saying, Neil, is that there may be a subset of patients who don't have CPX-351 eligible phenotype or genotype as currently defined, but might benefit from it. That's all I'm saying. But it's just a hypothesis that needs to be tested based on that paper I just showed you.
But again, up to this point in general, have you been using CPX in secondary AML, either from MDS or, prior chemo with solid tumors?
I have been in chemo-fit patients who don't have a p53 mutation, who have secondary AML after prior treatment, or have MDS-type chromosomal abnormalities. I will use CPX rather than 3 and 7. But I'll give good thought to using aza-ven in those patients, even if they're not in the approved indication because they're not over 75 or have a comorbidity.
And incidentally, what's your experience with CPX as opposed to 7+3?
My experience
in terms of tolerability.
People don't lose their hair. It's better tolerated, I think, except it does have prolonged myelosuppression. But it doesn't have the mucositis, so other than worrying about the patient a little bit longer, they don't tend to die of, neutropenic colitis, which was what kills people. So I think it's at least as well tolerated as 3 and 7, and probably a little bit more effective in the right setting.
And are you giving it inpatient? I hear some people give it as outpatient and then admit the patient later.
That's what I do if the patient is not sick, because it's basically cost shifting from the inpatient service, which usually gets DRG-based remuneration, to the clinic where they can bill the insurance company. It's really silly, but it does save hospital days and probably is a good use of a more efficient use of resources if you can do it. Yeah, so I give the CPX 351 on days 1, 3, and 5, or is it 1, 3, and 7? Anyway, I give the CPX 351 over the first week in the clinic, and then I admit them around day 10.
All right, magrolimab, I'm going to hear about that for sure.
Sure. So magrolimab is the it girl for AML right now. Whether that'll turn out to be a passing fad or a reality, we'll have to wait to see. But magrolimab has this unique mechanism of action, which everybody loves to say because it inhibits a, quote, don't eat me, unquote, signal on the surface of the leukemic cell, or for that matter, other cancer cells. Of course, these CD47, which is the don't eat me signal by the CD designation, is also present on red cells, so it can cause anemia, hemolytic anemia as well. But there's ways to get around that by this ramp-up dosing. Anyway, Dr. Naval Daver from MD Anderson presented a triplet study of aza-ven plus magrolimab in upfront and relapsed AML patients. And you can see the dosing regimens here, varying a little bit according to which cycle. There's a ramp-up during cycle 1, a little bit more frequent dosing of the magrolimab in cycle 2, and then twice during the monthly cycles after that. So again, the initial results, as they often are quite exciting. If you look at the frontline patients, the CR rate is 50%, but about the same in p53 mutant patients as it is in p53 wild type. Again, whether the response rate's going to translate into better long-term survival is really the issue, which I'll mention again in a second. The count recovery wasn't prolonged by the use of magrolimab, and in those who respond, about 2/3 of them do so at MRD negative by flow cytometry. I think one of the most interesting things about this abstract is that he did a comparison, as they're wont to do at MD Anderson. They don't like randomized trials, so they look back at their old data and try to do what's called propensity matching, which is not the same as randomization, looking at AVM, which is aza-ven magro, compared to HMA-ven, which, as we discussed a lot, is the standard of care. And it seems like, according to a log rank test, AVM was a bit better in terms of survival in this p53 mutant patient group than HMA-ven. The problem is neither group fared that well, and eventually most of the patients died within a year and a half, which is sad. So whether this is going to be, but still any step forward in this tough group would be great. So the company that owns this drug is doing two trials. One is called the ENHANCE-2 trial of aza-ven versus aza-magro in p53 mutant patients. That's ongoing, and also ongoing is aza-ven versus this this triplet that Dauber presented in all newly diagnosed unfit AML. Obviously, there's going to be some overlap because p53 mutant patients are eligible for both trials. So we'll see what happens when the enhanced trials are read out. It'll take a couple of years, but survival will be the primary endpoint. Another abstract that Novel presented, which I thought was interesting because it may turn out to be a drug in the future, or at least a class of drugs that people will find interesting, which is an antibody drug conjugate to CD123, and it has a generic name called pivekimab, and he did a triplet with pivekimab, aza, and ven in newly diagnosed and mainly relapse refractory patients. This pivekimab was combined with aza-ven in the schedule shown here. And I think what's interesting was a 50% CR rate in newly diagnosed AML, maybe a little higher than you'd expect with aza-ven alone, depending on the patient subtype. The nice thing was no veno-occlusive disease, which you do see with the more traditional antibody drug conjugate that's approved in AML, namely gemtuzumab ozogamicin. Myelosuppression, which you'd expect might be worse with a molecule that attacks the primordial bone marrow stem cell, was said not to be worse than what was seen in relapse refractory AML. So you'll need to do a randomized trial of aza-ven versus plus or minus this drug. Whether that's going to happen, I don't know.
Yeah, I was going to ask you, I know you're going to talk about magrolimab with MDS, but I was going to ask you about the anemia that you see, in the initial stage of using the drug. I don't know if you've had experience yourself with the drug in terms of the timing and how much of an issue it is, and how you see this getting translated into community-based practice. How much of a problem or challenge is it?
I think it's going to be a significant challenge because of the need to keep the hematocrit high. So you have to have good blood bank resources. We've been able to do it here without too much trouble. Yes, we've participated in all the trials I mentioned, the Enhanced 1, Enhanced 2, Enhanced 3, and some of the prior ones. It does cause anemia, so you have to be ready for it. And the drug was on hold for a while last year or the year before because of severe anemias that occurred. And so they've taken a mitigation strategy, which means you got to buff the crit up, which seems to take care of the problem. There are other anti-CD47 agents that, due to certain engineering, don't seem to cause the same degree of anemia. So those may be more interesting, but magrolimab is way out in front. So as a first-in-class molecule, it'll be the first one to have a readout. I don't think it's going to be, if it really prolongs the survival of people with p53 mutations, I think it'll be a side effect you can put up with.
All right, please continue.
So now we're going to go on to a class of drugs that I think will be a winner in terms of approval in the near future, which are the menin inhibitors. And again, this is close to my heart because a lot of the preclinical work that led to the development of menin inhibitors was done by my colleague Scott Armstrong here at Dana-Farber, who's head of the pediatrics here at Dana-Farber. There are two drugs, revumenib, called SNDX5613, and one called ziftomenib, that's KO563 or something like that. The first one I'm going to talk about is revumenib. Revumenib interacts with menin, whereas menin interacts with a very large number of proteins in this transcriptional activation complex called the menin-MLL complex. It disrupts the complex. This complex is needed to turn on genes which are pro-leukemogenic, namely the HOX-MEIS cluster of genes. So simply put, revumenib disrupts that transcription factor, disrupts the turning on of these genes. So any leukemia that depends on this transcriptional complex could be affected by a good menin inhibitor. The two main types of leukemias that we know about that depend on this complex are the MLL, now called KMT2A, rearranged leukemias, which account for about 10% of AML, and also some ALL patients, a high degree of infant AML, and second type is NPM1 mutant AML, which is much more common. Of course, it does well with chemotherapy, but there are plenty of people who relapse. So many people have shown that that revumenib and similar molecules disrupts the complex, turns down the gene clusters, and kills cells that have the appropriate genetic makeup. So the first study of revumenib was updated by Dr. Issa from MD Anderson. We participated in this study, as did Memorial Sloan Kettering and a bunch of other institutions. And the response rate in this relapse refractory NPM1 mutant and KMT2A range population was very good, 53% overall response rate in the efficacy population, 20% CRs, 10% CRH, which is almost as good as a CR, and a bunch of responses that didn't have count recovery. And this occurred both in NPM1 mutant AML with a slightly lower response rate and a slightly higher response rate in MLL or KMT2A rearranged AML. Somewhat similar, but not quite the same results were seen with the other molecule that's being tested right now. There's actually a lot more than these two, but these are the two that presented, called ziftomenib or KO-539. And again, they looked at two different doses. If you look at the higher doses, less patient numbers, but there was a similar 30% response rate and overall response rate about 40%. And the CR rate is a little bit lower in the NPM1 patients, but in this molecule, it seems to be more active against NPM1 relative to ML rearranged to the revumenib, although we don't really know if that's really true or if that's just luck or whatever. But so these two agents will be combined with aza-ven. They'll be combined with 3 and 7 in randomized trials. They'll be, I'm sure, presented to the FDA for possible approval based on these data, because there is no really other effective therapy for relapse patients, particularly with KMT2A rearrangements. So they may go the way of the IDH1 and IDH2 inhibitors and get approved without a control group.
What's the incidence of KMT2A, and also maybe remind us the incidence of NPM1?
Sure. So the incidence of KMT2A is about 10% of AML, 80% of infant ALL, and about 10% of ALL as well. 30% is NPM1. So it's not that uncommon in AML. I think next to FLT3, it's right up there with FLT3 in terms of incidence.
And the idea is it's not going to be used as part of upfront therapy in just people with NPM1?
No, it may be. It may be. There's another, we'll come back to this in a minute. There's another drug, class of drugs called SYK inhibitors that seem to work in NPM1 and KMT2A rearranged leukemia. They're being tested. So different mechanism of action, but same idea. Turn down that Hox-Mies cluster with these drugs.
I never thought to ask this, but what's the effect of aza-ven in NPM1?
It's pretty good, actually. It's better than aza, clearly, and the studies have been published. It works pretty well. But whether adding this drug to it will make it better is going to be an open and tested question soon.
It works well, but not as well as 7+3 in younger patients?
Well, we don't know that. I mean, nobody's given, to my knowledge, aza-ven to younger patients with NPM1 mutations.
No, I meant these new drugs, these menin inhibitors, are not going to be. They're not going to be used up front.
They will be, but in combination,
patient.
it'll be the same developmental pathway as in midostaurin. They'll be used with 3 and 7 as adjunctive agents, I think.
What's the roughly what's the cure rate right now with just NPM1 and 7+3?
7+3 NPM1. If there's no FLT3 mutation, it's about 60 or 70%, so it's pretty high. But it doesn't mean we couldn't improve upon that.
Right. Could be higher, yeah. Okay, please continue.
So while we're on the topic of the Hox-Mies gene cluster, this was a paper you picked. It was a preclinical paper looking at SYK tyrosine kinase inhibitors, but it will make the point that there is an ongoing large phase 3 trial in NPM mutant AML, which segues well to your last question. It's called the Agility trial. So entospletinib is a SYK tyrosine kinase inhibitor. The company that makes that has another one called lanraplenib, which they showed in preclinical studies was useful as a single agent and mixed well with gilteritinib or venetoclax in the right, and menin inhibitors in the right subtype genetically. But the point here is that since SIK is associated with some signaling molecules that turn on the HOXA9 MEIS1 gene cluster, this entospletinib and perhaps lanraplenib will be effective when combined with chemotherapy in this genetic subtype of AML, namely NPM1 mutant AML. So the company's making a big bet on this, 3 and 7 alone, or 3 and 7 plus or minus entospletinib. And of course, eventually there'll be a 3 and 7 plus menin inhibitor versus 3 and 7 trials we just talked about. So it's getting to be a busy AML subtype.
I don't know about these specific SIK inhibitors, but I know that right before BTK inhibitors came out in CLL, there were SIK inhibitors being presented in CLL, and I guess they just got pushed aside by the BTK inhibitors.
Right.
But I assume that the mechanism here is completely different. I don't know.
Well, yes and no. I mean, this interrupts signaling. These SIK inhibitors do. SIK is associated with FLT3. It's associated with ZAP70. So it actually has rheumatological indications as well. It's immunosuppressive too. So, so I think it's pleiotropically active. So I'm now going to move on to a plenary talk, which was a very interesting trial that could potentially, if people believe it and are willing to deal with the caveats, could potentially someday change practice. And this was a trial done by our German colleagues, led by the SAL Leukemia group from Germany, in which they tried to understand the best way to treat a relapse refractory patient with AML. Historically, the standard of care has been the top regimen. You give salvage chemotherapy, and then you do a stem cell transplant if they respond. Of course, if you don't respond to standard chemotherapy, you don't get a transplant, and that's that. Plus, a lot of these people get really sick with their salvage chemotherapy. A lot of other people have wondered, well, why don't you just take these people directly to transplant? Our transplant colleagues have always, to my mind, at least the ones I've talked to, have looked askance at this, because they say, well, I'm not going to take a patient with active disease to transplant. They're just going to relapse. But these German investigators said, well, we can just, if they're not too hot, we can just give them a little low-dose Aracia mitoxantrone, and then we have this super-duper conditioning regimen, which we call FLAMSA, using fludarabine, amamsucrine, and cytarabine. We don't have amsucrine in the U.S., but the idea was use a good conditioning and don't do too much. That was called disease control rather than the standard reinduction strategy. Now, the fine print was that they transplanted the people who responded, which is what we do in America, but they also ended up transplanting a lot of people who didn't respond. So it was basically transplant versus transplant. Nonetheless, they showed that it was non-inferior to take them right to transplant. So I would call this, whether you looked at, so the disease control is in the light color and the remission induction is in the darker color, I guess it's blue. And the survival rate, both leukemia-free survival from day 56 or leukemia-free survival from randomization, was the same. So I'd say these are very provocative data. I've talked about this with our transplant group. They're not crazy about the idea at the moment. They're still wondering we can do better by giving them some chemotherapy beforehand to lower the disease burden. But I think it's an interesting concept, and we'll have to see how this is accepted by the community. I know our transplanters not going to accept it today, but we'll see how things go in the future, and we'll see how things go when the paper is published and people have a chance to really look at, kick the tires a bit more on this data. Okay, so now we're going to finish up with MDS. We're going to look at some long-term follow-up or the of the medalist trial, which was luspatercept versus placebo in patients with ring sideroblast low-risk AML. Remember, the primary endpoint was met, whereas the luspatercept, which is given every 3 weeks to patients with lower risk AML with ring sideroblast, They had a significant decrease in their 8-week transfusion independent rate, and there was also a decrease in subsequent transfusion independence. The overall survival, however, in the two groups was the same. However, in the very low risk patients and those with high baseline platelet counts, they seem to actually benefit survival-wise from the luspatercept. And of course, if you look at these survival curves here, you can see that people who responded to luspatercept did very well. People who responded to placebo did pretty well, but of course, that's a rare number of patients. So this just confirmed the long-term lack of noxiousness from the luspatercept in this luspatercept versus placebo trial that led to its approval for ring sideroblast anemia or those with less ring sideroblast but with an SF3B1 mutation, which is a favorable group of MDS patients. So this was a trial from Cleveland Clinic. It was a retrospective look at people treated with luspatercept. They looked at people who were on luspatercept for more than 3 months, so it was a selected patient population. Most of the patients did not have the dose increased as is in the package insert. If you don't respond, you're supposed to dose increase. Most people stayed on the starting dose, which is 1 milligram per kilogram. And actually, in the real world, most people did convert to a lower transfusion burden, which proves that if you're in a good center and you pick your patients wisely, the drug really works as advertised. And I showed you in the previous slide that the long-term results are okay.
Can you comment on your own personal experience with luspatercept? Do you do the dose increase? And when do you decide to kind of give up on it?
Yeah, that's a great question. I do have a lot of experience with luspatercept. We do use it a lot in our low-risk MDS patients. Usually you find out within 2 months whether it's going to work or not, which is roughly 4 administrations, which is 12 weeks. I guess that's 3 months, whether it's going to work or not. If after 2 to 3 doses, I will increase the dose if there's no response, but I can't really say there's a huge dose response. Usually if they're going to respond, they do so. Also, there's a small but significant minority of patients who get quite tired on the drug, which defeats the whole purpose. If you make your hematocrit go up and you get tired, it's no great shakes. But like anything else, there are some patients with dramatic responses. There are some patients with piddling responses. There are some patients with no responses. But it's certainly worth doing. Except for the occasional fatigue, it's well tolerated.
And is that fatigue, do you think that's a side effect of the drug, or what's it?
I do. I mean, some people have MDS. People with MDS have fatigue even if you make their hematocrits go up, and that's because of the cytokine release that occurs in some patients. Luspatercept, to a certain degree, it's a negative cytokine trap, so it should help that. As a matter of fact, luspatercept is being tried in the myeloproliferative neoplasms like myelofibrosis because of its anti-cytokine effect. And there are some early reports of it being successfully used there. But we'll have to wait and see on more data. So I do think it's a weird side effect that I can't explain in some patients.
But, you know, the idea of fatigue being a cytokine side effect in general, and also the idea of luspatercept affecting cytokines, honestly, that's I hadn't heard that before. Could you just elaborate a little bit more on that?
Sure. Well, the mechanism of action of luspatercept is to be a trap of cytokines which are believed to promote anemia in MDS, right? That's how it works. Now, whether that's really how it works, only God knows.
You consider TGF beta? That's considered a cytokine?
Yes, and that does produce anemia. Yeah.
Huh.
Exactly.
Interesting. And do you think that the idea of fatigue as a consequence, I was just thinking MD Anderson has a fatigue clinic. Do you think there are other situations where, and people are always trying to figure out why cancer patients have fatigue. Do you think this idea of it being related to cytokines may be more, widespread than we think?
I do. The problem is, most of the agents we have, like this one, take out 1 or maybe 2 cytokines, and it's probably a cytokine milieu that you're dealing with. That's why some people respond to steroids. If we had a general cytokine drug that didn't make people immunosuppressed, I mean, indeed, ruxolitinib probably works that way in some people with myelofibrosis, right? It does improve the symptom score in people with myelofibrosis. And that
sure.
is a more general anti-cytokine drug. It does turn down the JAK-STAT pathway, which is a pro-inflammatory pathway. And what's inflammation but cytokines? So it kind of is all rolled into that issue. The trick is to just get rid of the negative cytokines without getting rid of the ones that help you prevent you from dying from a gram-negative sepsis.
Wow, really interesting. Okay, please continue.
Yeah. So this is the long-term results, also presented by European colleagues, in this case from Spain, of the so-called Sintra-REV trial, which was studying lenalidomide versus placebo in non-transfusion-dependent low-risk del(5q) minus patients. Now, remember, years ago, Dr. List published a paper in the New England Journal of Medicine where lenalidomide had a very high response rate in patients with del(5q) minus MDS, and there was it got approved on that basis. Not only does it improve the anemia in such patients, it also, in about 2/3 of those patients, actually removes the chromosomal abnormality, the 5q minus that causes disease. But when lenalidomide is used, let's say post-transplant in myeloma, there's a higher incidence of secondary leukemia. So the Europeans were very cautious about this. They wanted to test low-dose lenalidomide, 5 milligrams per day for days 1 through 28. We use 10 milligrams per day on days 1 through 21 of each 28-day cycle, or days 1 through 28, compared to placebo in these 28-day cycles. And they presented what they call the final results. These are in low-risk patients, of course, so it's very important not to cause any harm to these patients who are going to live a long time with minimal side effects. And what they showed was that those who respond to lenalidomide, which is a lot of them, have quite a favorable survival compared to those who are exposed to placebo. So this shows that low-dose lenalidomide is very effective. There was no increase in AML in the patients studied. The TP53 clones, which were supposed to not respond to lenalidomide and actually be selected by lenalidomide, seem to respond in this case, maybe because of the low dose. So that part of this trial is very interesting, that the TP53 clones seem to decrease, but it seemed to be extremely useful, and at this low dose, and no important side effects. This last abstract from Dr. Zeiden, my colleague from Yale, is really a trials in progress, and he wants to see if you can replace aza-ven, or at least aza, with this oral decitabine cytisiuridine combination, which is approved now as a single agent in MDS. So he's taking an approved single agent in MDS and he's combining it with magrolimab. The problem with this trial is that maybe next year or the year after, we'll be using aza-ven in MDS as well, based on the Verona trial that's being conducted by the company that makes venetoclax. And that Verona trial is simply like the VIALE trial of aza versus aza-ven, but it's limited to the WHO definition of MDS. You have to have 20% blast or less. You have to have high risk or intermediate high risk disease. So if that trial is positive, the fate of this trial is unclear. But it's an interesting approach of using magrolimab with an oral HMA. And that trial is just beginning. So the last trial is also presented by Dr. Zeiden, which was a randomized phase 2 trial, which was a bit disappointing. This was testing, again, in higher risk MDS, either decitabine or azacitidine, which is the standard of care, along with the prior oral agent I mentioned. So you could use either decitabine or azacitidine with placebo or with sabatolimab. Sabatolimab is a checkpoint inhibitor that's supposed to work in a fashion analogous to pembrolizumab and nivolumab, etc., do in solid tumors. Sabatolimab is a TIM3 inhibitor, which is another checkpoint. There was some somewhat encouraging phase 2 data presented by my colleague down the street, Andy Berner from MGH, using sabatolimab plus aza. in which there were some durable responses. Unfortunately, in this phase 2 randomized trial, the primary endpoint of complete remission or progression-free survival was not met. This is the overall survival and leukemia survival were similar in the sabatolimab HMA to the HMA alone. So this was considered a disappointing trial by many. There's a larger phase 3 trial that's ongoing. Whether they'll continue that or not remains to be seen in light of these relatively disappointing phase 2 results. I didn't want to end on a down note, but I did because whether checkpoint inhibitors will have a role in AML or MDS is still very much of an open question. In MDS, we're most excited about the possibility of venetoclax being a real drug in that disease as well. So that's my take of AML and MDS at ASH, based on the abstracts that were selected and a few that I added. And I really appreciate the opportunity to talk to people about this. Happy to answer questions.
So just a few questions. I never thought about this, but if you give sabatolimab alone, do you get autoimmune toxicity? Like
there were a few autoimmune, there were a few autoimmune toxicities seen in this trial, and in the trial that the precursor, a non-controlled trial that I mentioned, they weren't dramatic and they didn't seem to be associated with responses. So it's not a big problem, but unfortunately, it may be a moot point.
Right. I also wanted to ask you, there was a paper presented at ASH looking at survival outcomes in patients who got subsequent therapy after discontinuing oral azacitidine in the Quasar study. I don't know if you're familiar with that paper or any thoughts in general about where.
I didn't see it, but I will say still the Quasar trials really is interesting, but it applies to so few patients that, I think I've written one prescription for oral AZA. I mean, I think oral AZA is an interesting drug itself, but in the context that it was approved in, that is to say, people who were well enough to get aggressive chemo, but not well enough to get a transplant, basically. So who are those people? I don't know. Not many.
Right. And, speaking of oral AZA, where do things stand? Stan, you mentioned, using oral decitabine with venetoclax, but I know oral azacitidine is much more complicated, not as straightforward. Is that ever going to happen? Oral azacitidine plus venetoclax?
I don't know if the drug company is going to develop in that way, but there was an oral AZA randomized trial in lower risk MDS that actually caused a decrease in transfusions. It was published by Guillermo Garcia Monero, but it's not going to get approved because it caused a bunch of myelosuppressive deaths and problems in the early stages. I mean, it's probably not worth trading a few early deaths for a better transfusional outcome, which is basically what the trial was. But maybe it was the drug was, the dose was wrong or the duration of time was wrong. Anyway, I don't think oral AZA is going to be worth the trouble in MDS. We already have an oral drug that can be combined with Ven, that is, say, higher risk MDS. The oral AZA may have a role in a maintenance therapy, maybe after AZA-Ven in older adults, or maybe in the maintenance after transplant. There's a lot of ways to use it, but I don't see the path forward to anything beyond the Quasar trial right now.
So another question occurred to me. We were talking about secondary AML. Actually, tomorrow night we're doing a big webinar on myeloma with Joe McHale and AJ Nuka. And of course, they're going to be talking about the determination trial. And Joe, gave the discussion at ASCO. And one of the issues I haven't heard talked about too much, I mean, I guess it wasn't unexpected, was the increased incidence of AML in the transplant group. And I wonder if you have any comment on, in general, how you view the risk of secondary AML in people who get autologous transplant in general, and specifically in myeloma in the scenario that it's used.
Yeah, this issue's been discussed, and I've discussed it with my myeloma colleagues here and elsewhere. It turns out that I do see some of these patients occasionally, unfortunately, but the benefit of lenalidomide maintenance seems to outweigh those few patients who get AML. In other words, even accounting for that, it's still a better deal. Now, whether you can change the dose or give it intermittently so it won't have this effect remains to be seen. But there's clearly an interaction between the melphalan that's used for the conditioning for these transplants and the myeloma the lenalidomide that's used afterwards.
Oh, that's interesting. I never thought about that. So do you think that the incidence of secondary AML therefore is higher in autologous transplant in the myeloma setting than in other settings?
Yes, I do. Actually, melphalan is particularly toxic to the bone marrow stem cell and may select some of these for some of these difficult leukemias, and maybe that's enhanced by the use of the IMiD.
This concludes our program. Special thanks to Dr. Stone, and thank you for listening. This is Dr. Neil Love for Oncology Today.